Welcome, everybody. I want to call this AAPC Social Hour, but it is not. We'll call this a Wednesday afternoon drop-in with our friends in the AAPC world. Got my friends Missy, Kelly, and Jackie with me. Hey, guys.
Hey there. Hey, Alex. Hey, buddy.
And surprise to everybody out in the digital world, our friends out there. I'm going to share this in the AAPC Facebook group. We just wanted to drop in, talk about CDI, clinical documentation improvement. Yes.
Yeah. Yes.
And well, as we everybody, I see a few of you guys joining us right now. Let us know where you're at, how you guys are doing. I was saying to Jackie as we first connected that I'm struggling to recover from Labor Day weekend. I didn't do anything spectacular, but I'm just trying to get back in the groove. Oh my goodness, I see Sharon Oliver has joined us. Hey, Sharon.
Hey, Sharon.
Are you thinking Tuesday, Alex? Is this like a Tuesday for you?
It does feel like that.
When you're off? Yeah.
It does feel like that. But you, Jackie, you said that you were busy.
I work all weekend. But however, to take a break, we did check out 2 new restaurants in the area, and that made up for the having to work all day. Enjoyed every minute of it. I like getting things done and off my plate, and I applied my CDI knowledge at the same time. I tell you what.
That's awesome.
Oh, didn't know you could do such a thing. It really exists. It's a real thing. CDI.
Well, Kelly, how are you?
I'm good. Also a little thrown off by the days off, the extra day off this week, but doing great.
All right. Missy, life good?
Life is good. Kids are all back in school.
Yes.
Or back at work. Yeah. And no complaints.
Okay. Yeah. I hear you on the kids back to school. The house is a little more quiet while I work nowadays. So I forgot what that was like. That the summer kind of gets feeling long as we get into August. But just a reminder, everybody, this is not AAPC Social Hour because that's the second and fourth Wednesdays. This is just a fun drop in to talk about CDI, clinical documentation improvement. This brief discussion, we're only going to be on for about 30 minutes, you guys, but we just wanted to talk about what it is, maybe give some feedback or give a summary for those who may not who may not know what it is. So we're just going to kick this off. Missy, would you mind? I'm putting you on the spot here. Clinical documentation improvement. What is that? How does it fall into the medical coding world?
So it is that process of making sure, and ladies, jump in on this if you want. It is that process of making sure that our documentation is accurate and complete and fully paints the picture of what's happening with the patient.
So go ahead, keep going.
No, go ahead.
I was just going to say, just tag on to that. It depends on where you are in the process of that revenue cycle. So when we think clinical documentation improvement, those on the inpatient side have the ability to kind of review notes before they go out the door and can query providers. Like you mentioned this lab result, but you didn't mention anything about that diagnosis and the assessment. So I want you to pull in all the available clinical information. Now, on the outpatient office visit, sometimes, especially in an audit, that claim's already gone. There's nothing to query. However, I can provide comments. So when I'm doing an audit, I might see where the provider noted some clinical information, but did not pull it together into the assessment, and I can make it a comment. And some of y'all that are working in the world of risk adjustment and HCC, these are things that you typically do with your diagnosis coding. You're saying, oh, there was a missed opportunity. This was noted here, but you didn't pull it into the assessment and we didn't report the code. So I think that's what we're all kind of doing, is looking for opportunity, because I'm speaking from the audit side. We're looking for opportunity and we're looking for risk at the same time, especially if things were not noted. But the key part of clinical documentation improvement is clinical. We're not looking at levels of service. We're looking at, was there clinical information in this note that was not brought together correctly? And if possible, could you query the provider if there's that opportunity? Kelly, take it away.
Yes, so I have worked in the areas where we were able to query providers inpatient and try and get them to pull that information into their notes so that it was codable. Now I tend to use CDI information more for education purposes, because I'm more in the outpatient world. And like you said, it's the claims have already gone out at that point, but what can we take, and how can we use those patient charts to I guess coach and encourage better documentation in the future, so that those opportunities and things are captured? And how can we put that education in a way that's meaningful for the physicians to remember it and want to do it in the future?
I think for me personally, when the credential came out, I did the CDEO. I really just wanted more knowledge in this area, because I felt like my audits I understood the coding part of audits, but I felt like maybe I was leaving some opportunity on the table in this, just like what Kelly and Melissa talking about that education piece. So I got the curriculum, and it was an incredible curriculum. And I'm just saying I needed that extra, and the curriculum was put together in such a way that I was recognizing that I was probably reading some notes and not giving the feedback that I could have given before. So now when I'm auditing, and again, the inpatient world, you have that note right there, and a lot of queries are built around this process. Now, when I'm auditing, I'm looking for, you didn't pull this together. You made mention of these items. And again, I'm not clinical background. I'm not a nurse. I'm not, and even when I sleep in a Holiday Inn Express, I don't gain that knowledge overnight. And only people of a certain age will understand that one. But it helped me to better recognize opportunities, like Kelly's saying, for education. The curriculum was amazing. And I went on and got the certification to test my knowledge, because I really wanted to. And how I use it is kind of up to me, how far I want to go into that. But it's incredible information and knowledge I gained from having that.
I think on the outpatient side too, to tack onto that, on the outpatient side, even though those claims may have already gone out, when we use it for education, then it becomes something prospective.
Sure.
That we can use for future times that those patients come in, and it becomes a teachable moment, and it becomes really good education for the physicians, which is important when we start looking at risk adjustment, when we start looking at even some of those levels of service, identifying that you thought about the fact that the patients got XYZ condition. It's making sure that we're tying all of those pieces together to really, I love the phrase, to paint the picture,
Right.
to tell me the whole clinical story of what's happening with the patient.
With these guidelines on the outpatient side, sorry, Alex, we're just taking over.
I'm gonna leave now.
With the guidelines now, and especially counting data, it becomes so important to recognize when lab values have been reviewed, and then finish, like you say, finish the story. What did you do with those lab values? Because I can't give you credit, and it may give you data points as well as helping to paint that picture. What did you do with those lab values, and how did they affect that visit? So with that, with the CDI element, you are taking any part of this visit and saying, where did you miss the paint? Where did you not finish painting that picture? Yeah.
Right.
Okay, I'm gonna ask a question real quick.
Okay.
Okay.
Good luck.
May I, actually, I shouldn't say it. May I ask a question? Hey, so is CDI a singular job, an exclusive job? Can I apply for a CDI specialist or manager position? Is that a thing?
Places do that. Some will.
Yeah.
Some just make it a part of your total process.
Yeah, there's a couple of health systems near me that they actually have positions, clinical documentation improvement or clinical documentation specialist. Sometimes they tend to skew more inpatient, others, at least more, again, what I see in the outpatient world, it seems like it's the piece that really enhances the job that you do, because so many of the jobs can be done without the CDI piece and be perfectly acceptable, but that CDI element really enhances and benefits everybody involved when you're able to work that into whether you're coding or chart reviewing or all of that. It really does give just a much better.
As Jackie said, you don't have to have it, but when you do have that background, it really helps you to more completely give feedback back to the providers to really close some of those loops or close some of those gaps. I'm not a clinical person either. You don't have to be a clinical person to be able to do this. You just have to be trained to know what you're looking for so that we can explain it to the physicians. We sort of become that interpreter between the physicians and the billing to help them tie all of that documentation together and put it into a nice package.
And you're almost speaking their language. If we get into the piece, and I have to do my homework. Certainly, I don't know all these lab values always. Some, it's just over time you pick up on it. But I keep going back to that because a lot of it, that's where it's missed. Or if it's a comorbid condition and looking at signs and symptoms, I still have my Merck manual from 1992. It's still a good one, it still works. That was before, remember, it was before internet. So I had all that stuff. And I have to take my time, but it's worth taking the time. And then, like you're saying, Missy, when you get there with the provider, you're able to speak their language, and it's not, they understand that you really took the whole note into consideration, not just a level of service. It really kind of ups your presentation, kind of puts you on a different level with them, which is really nice if you've done your homework and you do that.
And that's the thing is you do have to, sorry, Alex, but you do have to do your homework because we do have to understand something about the condition. I can't just walk in and pick up a clinical oncology note because I will be lost. Clinical oncology is not my background. But if you walk me into an OB office, man, I'm right there.
All over it. Yes, Alex, sorry.
I have two comments I want to read. Lady Martinez, she is speaking back to a few minutes ago to you, Missy. She says, we should always look for opportunities to see how we can improve and educate the providers. And then Sharon Oliver says, you still need good base knowledge of the condition.
Very much.
Now, my question for you is, how does a coder know, or when in their career should they consider taking that step into CDI? What kind of things are they looking for? What is that progression and evolution in a career where they want to pull in this knowledge?
Well, for me, I started off in billing. I switched to coding. I did both inpatient and outpatient for a little bit. And it was around the time that I was like, all right, I've got a pretty good handle on what I'm doing, what could be my next step. And I started kind of watching what the other people around me did. And it was things to do with education that really got me excited. And CDI, I think, was kind of, I don't want to say it was a new thing. I think it was just becoming more widely adapted in how can we be proactive in the things that we're doing, and how can we use the people and the staff and the knowledge that we have and use that to our benefit. So it was around the time that I was like, okay, what's coming after coding? And then started, like I said, watching those people around me and figuring out more, where did I want to end up with what I was doing long-term. Did a little bit of auditing and could see how that could really piece together as well. And then actually got a job in provider education. And then I realized that I might have made that leap a little bit early, and there was a lot that I needed to learn to really get myself that good foundation. So I went to so many chapter meetings for things that I did not know about or think that I really was interested in before, just to try and do whatever I could to expand that knowledge base so that I could be a reliable source of information and be effective at what I was doing.
Missy, Jackie, how about you? I love that Kelly shared her step into the CDI world to kind of illustrate what a path may look like. What did that look like for you?
I wanted to speak the physician's language.
Yeah.
As I was moving more into risk adjustment, even when I was when the whole world was moving into ICD-10, I really wanted to understand more about the differences in conditions and what was driving physicians one way or another. And because of that, it drew me to the CDI world because it gave me a pretty good foundation. And what I didn't know, it taught me how to figure it out.
And that makes sense. And I'm kind of just like both of you. And for me, again, coding is one thing. It's hard if the practice doesn't allow for any type of QA time. Bills just go out, especially now with EMRs, things just go out the door. There's not always that opportunity to review. So on the outpatient side, a lot of it does become the audit. And like we've been talking about, there's that opportunity for education. So just like both of you, I went to audit and realized there had to be more I could be doing. And the CDI just seemed like the natural best next thing to do. If you're a coder right now and you're working in a practice, maybe once, or you're working for a consulting company and y'all have in some ways outsourced their coding, it depends on how much opportunity you have to question things and give feedback. If there's no opportunity there, maybe the CDI isn't the next step right now, because it'd probably just frustrate you. But if you have opportunity for education and to give feedback, then yes, it will help with your coding. Most of the time, it's going to help on the outpatient side with your auditing when you get into that step. On the inpatient side, it's going to help you if you're an inpatient coder and you're able to query providers, then this is a really good complement to what you're doing. And there is difference on those two sides of things because of the availability to get to the provider before a claim goes out the door.
Absolutely.
You have to think about what world you're in and what's your opportunity for involvement. And then, but at the same time, the CDI itself, the curriculum, the thought process is just helpful. It's how, if you're looking to immediately apply it, you've got to think about where you are and your opportunity for education and to provide feedback. Hopefully that's helpful. Yeah.
Okay, Teresa Amaro says it's so important to understand pathophysiology and the disease process to better educate the providers and know what to look for in the documentation. And our friend Lady Martinez says and this kind of goes back to what Missy was saying. She says, I'm a very curious person. I need to understand the whole picture. And Missy, you mentioned that you wanted to understand the provider language.
I want to be able to talk their language. I want to be able to translate what I know from a coding perspective to what the physicians need to understand from a documentation perspective, and be able to sort of bridge that gap where I see where you're going, but I need you to tell me a little bit more.
So I have a question. So I see, and this is not a plug, but might as well because I can. I see that y'all two and a few more are doing that workshop on the 28th for OpNote coding.
Yes.
So I think you'll probably be able to pull in some of this into that as well. with those indications in that operative report and being able to follow the reason for the operation, as well as, clinical documentation is not just the diagnosis codes. It's, did you actually document what you were doing? So that will come into play in that op note session as well. I mean, especially, and just because we're doing a lot of orthopedics right now, if you're not clear about the anatomy in that op note, so that means you have to understand the anatomy as well to be able to understand if the anatomy of the op note is reading as it should. So I think you'll probably be pulling it, without saying it exactly, you're going to be pulling in those exact same types of statements into your workshop, which sounds fabulous.
Absolutely. I can speak for my section of the workshop. I'll be talking about colonoscopy coding. And that's exactly, you have to understand those anatomical markers, understand what exactly it is that you're going to be coding. And do we see it documented in the medical record appropriately? Absolutely.
Perfect. Yeah. Yep. I gave it a shout out. It's going to be a good one.
We're excited.
We are.
Now, you shouldn't make your career decisions all about money. It's about learning, education. But let's be real.
And a little bit of money.
Yeah, a little bit of money. What are the growth opportunities like for someone going into CDI, like from coder, production coder, or in any other role? When you get into CDI, is there a growth opportunity both professionally and earning wise?
Well, like Kelly was talking about, you can become the educator now, and that's usually that's an up in your career, educator, auditor, those are ups. So if you find that this information helps you move into one of those places, definitely. Plus, right now there's a lot of groups that are focusing on CDI and along with their risk adjustment and creating departments. So you're getting out of just the coding. So I say yay.
Absolutely.
I was gonna go ahead, Cal.
Okay. It's not just, you could start to dabble, like Jackie was saying, when you're just a coder, not never just a coder, but when your job is a coder, you could start paying attention to things there. You can move into auditing with, and again, really fulfilling your role more with some of that CDI knowledge. But then you can also, if your goal is to get into leadership as a supervisor or a manager, being knowledgeable and aware of this in ways to help your team to become better in these areas and identify those opportunities and chances for improvement just within your staff is fantastic. And then even outside the world of healthcare, again, in the education, obviously that's my happy place. But you can take that knowledge, and if your goal is to educate new coders coming in, the ability to share that extra information that you have with them earlier in their career, so they maybe give it a little bit more importance. So you're passing that on to the next generation, and they're getting it maybe a little bit sooner than I got it in my career, to really get them excited and motivated, and just one more area to be able to spread into. Okay, Melissa.
You really said what I was going to say. From an administrative, from a supervisory position, it's great to have that background, and it really does allow you to grow. And then also in the risk adjustment world, we need this background, we need this understanding in the risk adjustment world. That's kind of where this industry is going. We're moving away from heads and beds and looking more at quality documentation, looking more at the acuity of the patient's condition. And the way you find the acuity, the way that you figure out how sick the patient is to understand the clinical conditions that the patient has, and to be able to translate that into codes.
This conversation will live on our Facebook page. I'm going to throw it up on YouTube as well, because what a great discussion. Just giving an overview on what CDI is and how it could be the next step in your career.
I'm going to give a plug too for Sharon Oliver's session, because Sharon's going to be talking about the pathophysiology of heart disease.
Oh, yeah.
Cardiology is always the one that, even like our students, when our students are coming up, cardiology is the one that always gets them. And Sharon is one of the best speakers I've ever heard talk about heart
yeah.
disease. And I
Yeah.
know she's listening today, and I know that she's doing that session.
It's going to be
at
great.
DocuCon.
Good shout out. Yes.
Mhm.
Sharon,
She-
fabulous.
She's on here. So Sharon, you're amazing. I just want her comments are
Agreed.
hilarious. She says, this is like a family reunion on Zoom.
It is. And
Uh,
yeah, we had some great sessions. I'm looking forward to Rhonda Buckholtz is doing that with or without documentation challenges. I mean, how
Yes.
Oh, good one.
Yeah.
Mhm.
going back to our diagnosis coding should be great.
So I think wherever you may be in your CDI path,
Mhm.
whether you're thinking about getting into it or looking to refine your skills, learn more, this would be a great conference for you to attend. I believe, like our other conferences, the recordings will be available for you to watch afterwards. So yeah, if you can't get off work, then you can hop in and watch them at your leisure later. So, okay, guys. Well, we're 2 minutes over. We could have spoken about this for
We
an
could keep
hour
going.
easily. But thanks for joining me, Jaci, Kelly, Missy. Appreciate you. Hang on with me just for a minute. Just a reminder to everybody, thanks for hanging out with us for this impromptu drop-in. We'll have social hour next week as usual, as planned. But we just want to share a little bit about CDI, what it is, and maybe give a little information for those who are looking to get into it. Okay, we will see everybody later. Jaci, Kelly, Missy, hang on with me. Bye, everybody. We'll see you next week.
Bye. Thank you.
Hey, everyone.